I'm about to give you a helicopter view of what I think is going to happen in the future in 10 minutes, which is easier said than done. So I added some slides because I just want to reiterate that you do have some rights and you can make most of your time. Because one of the things I've noticed from every table I've been to is some of the frustrations you have because of the logistics in terms of getting your service. So I would recommend you go to the MS Trust website. And there's a wonderful little video there called Making the Most of Your Appointment. And so if you do only get down to Glasgow once a year to see Pushkar over here, you make sure you get what's out of him in those 15 minutes, you see him what you want. Okay, so this is actually a very, very good thing to prepare. And for those of you who've got poor memory, I'm sure you can ask your consultant if you can record the consultations. Several of my patients now do it routinely, and they can then listen back to it for the information. And so if you've all got smartphones, most smartphones now have recorder apps on them that you can use. And most consultants don't have a problem. Okay, just ask. Just to say to you that I'd recommend you read this document. This is a document we wrote about 2 years ago now. It's called Brain Health, Time Matters in Multiple Sclerosis, and it's about the need for us to speed up the management of MS and actually to treat to target and make things more effectively. If you go to the website, msbrainhealth.org, you can either download the full document to read, but there is one that's written very, very short just for people with the disease in much simpler terms with the core messages. Okay, and this particular document now has been endorsed by over 50 MS-related organizations across the world, including the National MS Society. So it's a way to try and activate the community. In addition to that document, we're hoping to produce a thing called the MS Advisor in the next 18 to 24 months. You know TripAdvisor? The best way to get this hotel to improve its service is if you give it a bad review. So the best way to get Glasgow to improve their service if you give them a bad review on MS. I've just been joking. But the whole purpose of the MS Advisor is to not actually ask you a satisfaction survey, but to ask specific questions around how you're getting managed. And so when we do put the patient checklist up there, it'll be about the holistic management of your disease, and it'll also be an app that provides you information about self-management and how to handle your disease. And we're hoping to get this funded in the next 12 months. This is actually my worldview of MS. Because I'm based in London, we drew a London tube map, and it's basically depicting MS as a train journey. Each little stop on the lines is a different aspect of MS management. And we'll also hopefully be putting all the issues in terms of how you look after the disease and how you understand the disease at each tube stop. So you just click on it, and it'll be a little bit of information for you. What's very, very important in this, you can see there's a grey line at the bottom with 3 stops on it. And that's actually dotted because it's under construction. And those 3 stops are long-term remission, MS cure, and normal aging. Because one of the things is we're trying to shift in the future the focus of our treatment targets. We're all going to get old one day, and what protects us from age-related memory problems is the size of our brain and the health of our brain. And so one of our treatment targets in MS is actually to see if we can maximize what we call brain health. For that, and that's part of the shifting paradigm in MS, is to try and protect the brain. And we can do that now with more effective therapies. So as we move up the treatment thing, they're getting better and better at preventing the shrinkage of the brain that occurs as a result of MS. You need your brains for old age. Self-monitoring, we mentioned it a few times. And so there's a whole reason why you want to monitor yourself, because if you're monitoring your walking time, your upper limb function, you will actually be able to say to your neurologist, I'm actually improving, which is good, or I'm stable. But also if you're getting worse, you can then ask the question, why am I getting worse? Is it because my MS needs to be treated better, or do I need new therapies? So having that information yourself is very helpful. And we did a survey on our blog, and actually you can see there, the majority of people who responded to the survey actually thought the idea of self-monitoring is a good idea. So that's why we've got these things like the 9-hole peg test, the time 25-foot walk, the online EDSS calculator, is to activate you to actually know what MS is doing to you. So when you go to your neurologist, you can give them the information and ask them if they can do anything better. And so if you go to Clinic Speak, you'll find the tools. Eventually, they'll all be in one single app, and we'll be able to post out a box to people who require it for the 9-hole peg test and the string to measure the 25 feet. I put this in because the mouse doctor asked me to talk about this last year. Stem cells is a very topical thing at the moment, and I met a patient over there who's just come back from Mexico at great expense to the island to have a stem cell therapy. We actually offer this, and it's been promoted quite heavily recently on the BBC News. And the principle is very, very simple. This is not stem cells to repair the brain. This is stem cells to allow you to have much more aggressive chemotherapy. And the idea is to deplete the immune system, and then the stem cells are allowing the bone marrow, your immune system, to recover much, much quicker. The thing about this particular procedure, it's probably effective, but we don't know how effective it is because it's never been compared to existing therapies. So the good news is the NIHR, which is the National Health Service research arm, is almost certainly going to fund a national study comparing this HSCT, this bone marrow transplant technique, against one of our most effective therapies called Lemtrada, alemtuzumab. And the reason why we need that is because we need to know, is it really better than that? To stop people having to spend £50,000 going to, was it 43,000? It's 43,000. £43,000 to go to Mexico to have the treatment. And for those of you who asked the question, this treatment is actually available right now in the NHS. It just depends on the kind of MS you have, and so we're offering it in London. I know it's been done in Sheffield and quite a few other centres. I'm not sure if it's been done in Glasgow. The next big thing is prevention. So I know you live on an island where you're at very high risk, almost double what it is in the southeast of England, and we now know that there are quite a few risk factors for MS. The virus that causes glandular fever, infectious mono, is one risk factor. Most people get infected with it. We need to test the vaccine. Have you already mentioned vitamin D? Keeping yourself vitamin D levels up all year round hopefully will lower the risks. And smoking increases your risk by 50%. So you've got to get the message out to all your family members, particularly the young people, not to smoke. We've also noticed there's another 3 risk factors that have come up and been confirmed. One of them is head injury. The other one is solvents, it's organic solvents. And the other one is childhood obesity. And we know, and the childhood obesity story is now being confirmed in a few studies. And so the question is, how do we prevent childhood obesity? We are starting a national register. Dr. Ruth Dobson, who works with us, will be starting on the 1st of May. On a part of her grant is to recruit a national register of young people at risk of MS. And so what we're trying to do in the register is get children and siblings of people with MS, because they're at a higher risk than the general population. And then those particular people will be profiled, and potentially when trials come up to prevent the disease, they will hopefully be able to volunteer to go into trials to try and prevent the disease. And I think the important message about this is that we're actually thinking about preventing the disease. I just heard from Chrissy, where's Chrissy? That last year you had 500 to 520 new patients with MS in Scotland. That's an incredible number of patients considering the size of Scotland. And I think that if we do prevention studies, we may reduce that, depending on what it is, by half potentially, and that would be something that would be worthwhile doing. Treating progressive MS, Dr. Schmierer, Dr. Kay already mentioned this to you. We just got some early observations though. I drew this picture this morning. If you go onto these treatments late, it takes a long time to see the effects of treatment if you're more disabled. So if you're already using a walking stick, it's very difficult to see the treatment effect within a year or two. It usually takes 3 or 4 years. And when we do see the treatment effect, it's usually slowing down or flatlining rather than improvement. On the right, when we use the treatments when people are more mobile, sometimes we see much more rapid effects, usually within a year or two. And we see often improvement in function now with our most effective treatments. And that's because it all depends on how much reserve, the ability to recover function it is. And this is the message is, to treat MS, we should treat it early rather than late. But even if we treat it late, we are still seeing significant changes in function. And I'll come back to one therapy. And Dr. Schmierer mentioned to you that it's the size of the nerve, the length of the nerve that predisposes it to degenerate from the MS quicker. So the nerves to the legs are much longer than the nerves to the arms, which is why the arms only get involved much later, and there's more reserve, so we see much more treatment effect in the arms. So this is one of the drugs that's coming. I don't know if it's going to get licensed or covered by the NHS, because the cost effectiveness modeling for this drug for primary progressive disease is based on comparing it to no treatment. whereas in the relapsing disease it's been compared to the existing treatments. So it's called incremental costs, is how much does it cost more than the existing therapies to get a license to be used by the NHS. In primary progressive disease, the price is going to be set for relapsing disease and going to be compared to no treatment. But in this particular trial, this drug's given every 6 months as an infusion. And you can see in the primary progressive people on the disability and walking, it delayed progression by about 25% compared to placebo dummy drug. That actually, when you model it out, means that people on the drug would take about 4 years longer to need a wheelchair. Is that a significant thing? It means remaining walking 4 years longer on the drug. When you look at the upper limb function was twice as effective. It reduced the loss of upper limb function by close to 50%, so, because the arms have got more nerve fibers. And when you model that out, it's probably close to over 8 years, about 8.7 years longer in keeping your hand function. Is that significant for people with MS? That's the question we have to ask when NICE says no, is that if they don't, because the people on those committees don't have MS, they just, you know, they call bean counters and economists. And I think maintaining leg and arm function is something for people with primary progressive disease that have no treatments is something important too. But anyway, I think we've had treatments for progressive disease for a long time. We just haven't done the trials properly, and we haven't actually interpreted the evidence properly. And so the good news for this group and going forward is that we're going to now have treatments for people with more advanced disease. We've got to do more trials because we need to get better treatments. But I think it means that the disease is modifiable across the spectrum. It doesn't mean it's just for early relapsing disease. We're going to have treatments for, and we are about to launch a trial of that same drug, ocrelizumab, again in primary progressive disease, and this time we're going to extend the eligibility for people in wheelchairs. So people in wheelchairs will be able to go into the trial, and the whole aim of that treatment then would be to try and stop them losing their hand function, to protect the hands. And so what we're doing is we're building a pyramid, and you've heard today that we've got to switch off the inflammation in the brain, because the inflammation is what primes the brain to degenerate. So we've got to stop the inflammation. And we've got trials running at the moment where we're going to add on therapies. So we're creating a sandwich, multiple medications, to protect the nerves that have already been damaged, to keep them alive. And then we're going to add on top of that therapies. And there are trials recruiting right now. We've got one in our center recruiting, where the drug is actually promoting remyelination to try and make that nerve function better. And then on the top there's therapies that are designing to restore function. And that may sound like science fiction, but it's not. What causes the nerves to regrow sprouts and to reform their connections is actual biological processes. And if you can actually stimulate those processes, you may encourage nerves to recover function. And so what we're trying to do is build a combination therapy strategy going forward to tackle the issues in terms of MS. But on the other side, there are lots of things you can do that will also help MS. Okay, all those lifestyle things you've heard about. How many people smoke in this room? People who smoke, yes. So people who smoke and got progressive, their disease progresses much more quickly, so you've got to stop smoking. People who've got poor sleep, for example, may do worse. People with recurrent infections, people who've got high blood pressure, diabetes, all these things actually make MS worse. So by targeting what we would call comorbidities, other diseases, we can also help slow down the processes. So there's lots to be done, lots to be done. So the future is about prevention, treating progressive disease, restoring function, and optimizing your brain health so people with MS can age normally. I mean, that's what our aim is.